Doctors, we can start now.
Okay. So, Assalamu alaikum, and I'd like to thank the organizers as well as the sponsor of this meeting and the Emirates Cardiac Society for giving us this opportunity to have a important symposium on the management of cardiovascular risk and dyslipidemia. It's my pleasure to present my very dear friend and colleague and mentor, Dr. Majid Zubaydi, who is known to everybody in this country. He's one of the leaders of the interventional cardiology as well as the cardiology community, and one of the leaders in the Emirates Cardiac Society. Leaders of Emirates Cardiac Society. He really is his achievements are too many to mention, but of course, in addition to thousands of lives that he has saved personally, also how he has created the interventional cardiology program and a very robust STEMI program in the UAE over the last decade. And it's something I'm very proud of to be part of his team and also part of this Congress. Dr. Abdul Majid, please, if you can.
Speak. Unfortunately, I can't, for some reason, I can't hear. I hear you on my laptop, but I will go ahead and give my talk because I got that signal through the message that the audience are hearing me. First thing I would like to thank Dr. Hani for the the introduction and the organizers for putting this together. Today my talk is going to be on the burden of cardiovascular disease and hyperlipidemia. So I got a few slides that I'm going to address the burden of the disease and that we are having a major problem, which is the risk factors for cardiovascular disease and the consequences of that, the consequences of having a high prevalence of cardiovascular risk factors and cardiovascular disease. So if you look at this map of the world, what you can see is the burden of cardiovascular disease. And this is presented here as number of deaths per 100,000 population. So the blue is low death rates or death per 100,000. And as the color changes towards the red, the number goes up. So advanced healthcare systems, they have a low death rate of cardiovascular disease. And the reason, or most of the benefit, came out of prevention initiatives and preventing cardiovascular disease. So in our region, in the Middle East, and if you look at United Arab Emirates and the rest of the Gulf countries, relatively we did a lot of good work over the last few years with the advancement of our healthcare system, but definitely we are not there yet. Still, there is a gap that we need to work on in terms of addressing cardiovascular disease, preventing it and treating it. Now, the same slide is presented again, but here on average life expectancy, because cardiovascular disease is the leading cause of death. Definitely it will impact mortality and life expectancy. And as you can see again here, we're doing better, but definitely there is a gap to improve the average life expectancy through improving the care of cardiovascular disease. This is a WHO data, death rate of cardiovascular disease in the Middle East, and you can see in some of the Western countries, the death per 100,000 is somewhere in the 150, and in the Gulf and some other North African countries, it ranges from 3 to 4 and 500 per 100,000 population. So again, and most of it is ischemic heart disease and cerebrovascular disease, and that is, atherosclerosis. And of course, we know all atherosclerosis, most of it is related to cardiovascular risk. And I'm going to show you that in the next few slides. So number one cause again in UAE and continuing to increase rapidly. This is 2007. If you look at this column here, and those are the ranking of cardiovascular deaths back in 2007. 2017, ischemic heart disease increased 175%. And there is and now it's the leading cause of death. So to add more insult to the injuries, those who are affected by cardiovascular disease are a younger age. So look at this. GCC patients comes with a heart attack 10 years younger than the average age. And this comes out of one of the registries, Gulf registries, called the Gulf Race. And what they did in this paper is they compared the average age of those who presents with heart attack compared to other international registries. And if you can see here, our patients present 10 years younger. So the number of years lost is very significant. So we lose young people because of this disease. So the reason why it's number one killer is we're having in UAE, dyslipidemia is the major risk factor for cardiovascular disease. And I can tell you this is across the world. So dyslipidemia is one of the major, if it's not the major risk factors for cardiovascular disease. And of course, diabetics are the prevalence of diabetes, 20%, 65% are overweight or obese, and those contributes towards dyslipidemia. Interheart study is a very famous study, and that study established the correlation between the different risk factors and cardiovascular disease. So risk of acute MI associated with multiple risk factors. So if you look here, if you're a smoker, your odds ratio of developing an MI is about 2 point something. If you're hypertensive, you're diabetic. And as you get more risk factors, just, the relationship between the odds of developing an MI and the number of risk factors is almost linear. And the number, actually it's more than that. It's so you look at the odds here. So someone got all the risk factors, his odds ratio of developing an MI is 256 or 512. So it's very, the correlation is very strong. And if you look at the Interheart study again, acute MI, more than 90% of MIs are attributed to these risk factors. So if someone doesn't have those risk factors, the likelihood of having a cardiovascular event is extremely low. So look at the prevalence of the different risk factors, and look at lipid or hyperlipidemia and the Interheart study, and 50% of those patients had hyperlipidemia. The elevated lipids have the greatest impact. Look at that. So the impact of population attributable risk for various risk factors of acute MI. So those are the lifestyle factors, and those are the factors that we can treat. So abdominal obesity, diabetes, hypertension, alcohol, lack of exercise, all of those factors are treatable factors, or factors that can be addressed either through behavioral changes and lifestyle changes, or through pharmacological treatment. On the other side, there's another cohort studies that looked at low risk cohorts. So if someone is at a low risk who doesn't have risk factors, as we saw in the Interheart study, those people or those patients doesn't have or their odds or their risk of developing or having a mortality related to coronary heart disease is very low. Look at this, what is called Mr. Fit trial or study, and it's men aged 35, 39, and they followed those patients or those people, that cohort, and those who does not have risk factors or considered low risk, their odds 0.2 compared to 1.5, and this is a younger age. The same thing in older age, you see the difference is very massive. So those who have multiple risk factors, they develop, they have a higher chance of developing MI. Again, prevalence is very, very high. We tend to underestimate it. And the reason is it's not diagnosed, patients doesn't seek, or people doesn't check or screen. And if they are diagnosed, they tend to ignore. So you can see here the prevalence. This is what's called ACE study, and it's Africa, Middle East cardiovascular study. What they looked at is, in this epidemiological study, is thousands of patients who attend primary health care, and they looked at the prevalence of dyslipidemia as defined by the international guidelines. And you can see here in those cohort or those patients, and I think these people were more than 40 years old, prevalence is very high. You know, it's almost 70% of grown-up adults would have a dyslipidemia. Now, in the same study, it's not just the dyslipidemia, it's the other risk factors. And of course, here today we're talking about, you know, hyperlipidemia and cholesterol, but when we're dealing with patients, we have to deal with the whole risk. And you can see here in the same study, this epidemiological study, the number of patients, or the percentage of patients who got more than 3 risk factors is what, 13, 30, more than 50% of the patients, or those people who comes to the clinics, would have more than 3 risk factors for cardiovascular disease. And if you remember the Interheart study, you know, if you're having 3 risk factors, the odds is very high. This is, again, this comes from STEMI patients, and patients who presents with ST elevation MI. In UAE, we have a good number of them are diabetic, a good number of them are dyslipidemic. So now the problem now is well defined, and we all know that you know, that the prevalence is very high. So we have to be vigorous in terms of looking for it, screening, and educating our patients that they need to give it an attention and not ignore those numbers. Now, this is a paper published back in 2007, New England Journal of Medicine. And what they did is they looked at obesity and diabetes in the developing world, a growing challenge. So if you look at the color code here, 2000, and this is 2030. So blue bars are 2030 obesity and diabetes in different continents. If you look at the Middle East, I want you to focus here, and you look at 2000, so 20% will have diabetes and obesity, or obesity. If you go to 2030, 50%. So this is a serious problem, and it's not going to go away. We have to address it. We have to be aggressive in terms of addressing it and looking at and educating our patients and our physicians around it. Now, this is not just patients who comes to primary health care. No, this is even patients who presents with acute coronary syndrome. So this paper by our colleagues in Al Ain, what they looked at is patients who presented with acute coronary syndrome. So ACS patients, total of 3,066 patients, and they looked at the different risk factors. So diabetes, overweight or obesity, and hypertension. And they looked at cholesterol. Look at the cholesterol, look at the black and the red or pink bars. And This is after 6 months. So this is the day they presented, or they during their admission, and they and this is sorry, and I'm just going to go back. So that's their baseline, and this is 6 months later. So 6 months later, no major difference. So the patient starts with LDL of 84, and then you see him 6 months later, 78. So that means that a good number of these patients are not taking their treatment, and they're not adopting an appropriate lifestyle. So there is a gap. So these patients, when I say acute coronary syndrome, so this is the highest risk patients that you can deal with. It's not just a patient who comes to the primary health care. Why there is a gap? Why those patients are not getting the treatment? Why are those patients not changing their lifestyle despite having a heart attack? Part of it is the patient, but of course, a big part relies on us as a clinician and as a healthcare community. We have what is called physician inertia. So this terminology of inertia is getting popular, and now it's heavily investigated and looked at. Why would a physician recognize the problem but not address it and not intervene? So I'm going to leave this for my colleague, Dr. Hani, later on. He's going to go into some details around how to address clinician inertia. Again, you know, when I talked to you, or I told you that acute coronary syndrome is a serious thing, and patients with acute coronary syndrome needs to have their risk factors addressed. Why is that? The reason is, look at this registry data. 16,000 patients in this registry who had myocardial infarction, no history of stroke or TIA. So 16,000 patients had a history of MI. Their chance of having another MI is 5% in a year. In 4 years, their chance of having an MI is 15%. And this is probably a registry where patients are having maybe a better, their risk factors are addressed in a better fashion. I can tell you, if we run this similar data on our patients, we may see a higher recurrent events for all the reasons that I talked about, which is, you know, a poor compliance from the side of the patients with lifestyle, with treatment, with the follow-ups, and also the clinician inertia part of it, or a big part is is us as a healthcare community. So risk factors can be addressed, you know, through a different fashion, you know, so diagnosis, appropriate diagnosis, referral, identifying those patients is very key. You know, if you don't screen, you can't tell. Dyslipidemia, hypertension, most of the risk factors that we deal with are silent. The patient would not come and talk and, you know, and complain of dyslipidemia. He will, you know, you have to screen them. You know, you have to address the vascular management. Sometimes as an intervention cardiologist, I see the patients, or I see patients, and we address the significant disease, what we call a significant disease, the lesions. We open those lesions, but we have to look at the patient as a whole vascular risk, you know, the whole vascular burden, and accordingly, you know, address or just, you know, prescribe the different treatment plans. You know, how aggressive in terms of risk factor are you going to be? That depends on how much vascular disease that patient has. Of course, obesity, insulin resistant, all those factors are very, very important. You know, there is a different missed opportunities for us when we see our patients. You know, in hospital, sometimes we discharge patients before addressing them on their risk factors, their risk profile. You know how many patients knows that when they get out of the hospital, their chance of having another MI within a year is 5% or 10%. or 20% in 2 or 3 years. So those patients, they need to know their risks so they can be more careful. So before discharging patients, I think it's very key that the patients are educated about, you know, what is their lipids, what kind of numbers they should be looking for, you know, in the follow-ups, you know, with the cardiologist, with their primary healthcare physicians, with their internist, all those opportunities with the you know, with the different clinicians that the patient is attending. I think there is an opportunity to help that patient and reduce his chance of having another event. And I can tell you the recurrent event or future event is not just an MI, it's not just a stroke, that can be death. So we have to be serious when it comes to you know, to handling these patients, especially patients who already developed evidence of cardiovascular disease. I think I'm going to come to the end of my talk, and I would leave the rest of the floor for Dr. Hani to continue and finish. And hopefully I fix my side here. Thank you. So Dr. Hani is a very close friend, and you know, he's a cardiologist, consultant cardiologist at Cleveland Clinic, Abu Dhabi. Dr. Hani is has a lot of interest in metabolic disease. He's an electrophysiologist with a lot of interest in a different also specialties in subspecialties in cardiology. I learned a lot from him when he was at SKMC, and now he's over at Cleveland Clinic. Dr. Hani, تفضل.
Thank you very much, Dr. Majid, for first of all, the very kind introduction. It's an honor and a privilege also to work with you on clinical as well as educational activities. So we have two presentations and some cases. So I'm going to start with, can you allow the screen sharing, please? So the first one is basically the evolving landscape of lipid lowering and risk lowering therapy. And we'll try to address the risk of lipid-related events in the cardiovascular disease patient. So we'll start with the focus on the recent MI ACS patient. Managing LDL on the updated guidelines, looking at real-world data in management, and some new data on cardiovascular outcome in the post-ACS patient and continuity of care issues. So here is a case. This is a 65-year-old lady who was hospitalized with an inferior STEMI and underwent a PCI in the hospital. She has a history of hypertension, dyslipidemia, no diabetes, and no family history of cardiovascular disease. Prior to the admission, she's already on a high-intensity statin and an ACE inhibitor. So blood pressure is 128 and 76. Lipid panel before admission in the outpatient clinic showed an LDL of 100, HDL of 36, and a total cholesterol of 167. Triglycerides 140. So this is actually an LDL of 2.5, and that's kind of an important point. In the hospital, her LDL is 90, and her HDL-C is 35, and total triglycerides is 145. So as Dr. Abdul Majid showed very nicely from the REACH registry, recurrent cardiovascular events are the highest within the first year of an event. And the fact that you've had a heart attack makes you much more likely to have another one. So 1 in 3 of those patients will have another heart attack. And this risk increases very rapidly within the first year. In year 2, among those patients who didn't have a major cardiovascular event, again, the risk is there. So if you censor out the first year, it actually goes up by a factor of almost 30% every 12 months. So this is a very serious business if you've had a heart attack, actually, in terms of your long-term risk. Now, this is the guidelines, and I think all of us have seen that there's been a lot of updates on the AHA and ACC guidelines. And one of the important points is this. If you look at cardiovascular risk, then you look at the LDL in that context. It's not a number that sits on its own. So the American guidelines talk about cardiovascular events, a recent ACS, MI, stroke, or symptomatic PAD, or a single cardiovascular event and multiple risk factors such as diabetes and hypertension. The European guidelines talk about documented cardiovascular disease such as imaging, a cardiovascular event, or revascularization. But they also tell us that diabetes with target organ damage, so a diabetic with hypertension or risk factors or early onset of type 1, CKD, and familial hyperlipidemia put them in a very high risk group. Across the board, though, the first line therapy is statins, followed by ezetimibe and or PCSK9. American guidelines target to an LDL of 70. This is the threshold to intensify therapy using non-statins as well. And the European guidelines have a dual goal. It's more difficult. A 50% reduction from baseline plus an LDL of 55. And in a patient who has had a recurrent cardiovascular event or an event on maximum tolerated statin, second event within 2 years, the target is 1.0 or 40. So not only 55, 40. It's a very aggressive goal if a patient's already on a statin. So how are patients like the one we showed being managed in the real world, and what is the risk of future cardiovascular events? So these cardiovascular studies, this is again the Ontario Cardiac Health Study, 47,000 patients undergoing their first PCI. Look at the LDL in reality. 15% had an LDL more than 100, 28% were between 70 and less than 100. So even with the American guidelines, still not compliant with the LDL target, okay? And actually, the higher LDL after PCI was associated with an almost doubling of the risk of myocardial infarction. Those patients in red and yellow, these are the same patients here, have a 17% risk or a 29% risk of myocardial infarction, almost double the person who has an LDL less than 70. So you see how bad this is if you leave these patients with an LDL more than that. And then other registries, this is again very important, only half the patients had high intensity statin after coronary vascularization. That is extremely dangerous. And in fact, these patients have had a PCI, have had a CABG, and still don't get intensified. So the majority are getting a lower intensity statin than a high intensity statin. This is a big problem in terms of physician perception and what we're doing for our patients. Medicare, as you know, is also a very big registry, contains a very big registry of patients over the age of 65. And the recurrent cardiovascular events are, again, very high in the first year and continue to occur over time. So this is 4 months after the first event, 8 months, and 12 months. So the percentage of MIs, ischemic strokes, unstable angina, and CABG seems to increase with time unless we do something about it. Now, this is one of the studies that was conducted in our region. This is the DICES-2 study, 18 countries. And in fact, some of our colleagues at SKMC were participants in this, Dr. Wael Mohammed in particular. And here you go. Again, patients after ACS, less than 40% of those patients in our region achieve less than 70 LDL within 3 months post ACS, okay? And as we said, the majority of patients should be less than 70, and by the European guidelines, less than 55. So we're not doing very well in this department as well. So there are multiple actionable opportunities and educational opportunities to lower LDL early and reduce the risk of future CV events. So the interventional cardiologist or the general cardiologist obtain the lipid panel during ACS. I think that's pretty obvious. And then educate the patient that the LDL is the most important modifiable and controllable risk factor with the greatest impact in terms of recurrent cardiovascular events, and always have high intensity lipid lowering in the discharge plan. Don't wait for it to happen at the time of this, after discharge, do it before they go home. And there's other steps that you can do, but this is the first step that you do in the hospital. After 1 to 3 months, it's very important that the following cardiologist repeats the lipid panel, re-emphasize lipid lowering, re-emphasize lifestyle modification, and if the patient is not reaching target, lipid clinic and cardiac rehab. 6 months, again, repeat the lipid panel. Associate the LDL to the risk of atherosclerosis and look at your lipid lowering therapy. And after 12 months, again, this is a constant program, again, check the lipid panel, reinforce to the patient the long-term benefit of LDL lowering in atherosclerosis, review the LDL targets, and see if more additional therapy is needed. So like our diabetology colleagues, we have to do this frequently, constantly, recurrently, and intensively. So initiation within the hospital is a serious business. And in fact, when you do it in the hospital setting, not only is the patient engaged and understanding, they're much more likely to continue that. So those patients who were initiated with LDL lowering, whatever it was, at the inpatient side, versus those who were initiated in the outpatient side, look at what happens at the time of discharge. Okay, 81%, 13%. 77% of those initiated at the inpatient will still remain on that. That is a very important strategy. And also, you need to emphasize this in the outpatient setting and make sure that the patients continue to be on the therapy, all right? And don't drop out. So there are many studies that have actually looked at the LDL lowering in the acute post-ACS period. Remember that the original add-on therapy, which was Improve It, was a post-ACS study, and they initiated within 10 days of the ACS event. Prove It, which was high dose versus high intensity versus low intensity. Again, treatment initiation was very early. The A to Z study, again, very important. Treatment initiation within 12 to 120 hours, 3 to 7 days after an ACS event. And Miracle, as you know, was related to ACS as well. And the treatment initiation was very early. And that's the whole point. This has to be locked into our mindset and how we tell this to the patients. So addition of statin therapy in acute ACS patients reduces the risk of events. But look at how early it happens. This is the Miracle study. Within 1 to 4 days of an ACS event, there is a 16% relative risk reduction and a 3% absolute risk reduction. But it actually, the curves start to separate within weeks, 4 to 8 weeks. And in the Prove It study, again, the early separation of the curves was observed at 3 months and continued because of the use of intensive, high-intensity statin with a Torva 80 all the way out to 30 months after follow-up. So the earlier, the more intensive, the better. Now, one of the things that people have used as indirect evidence is the use of plaque regression. There's a lot of studies historically about plaque regression using more intensity statin, more potent statins, such as Saturn, the Saturn studies, of course, and the reversal and asteroid studies. And here, when you see that the LDL has to drop below 70, this is the dotted line, where after 70, atheroma volume starts to decrease. So this curve here, this is 80 and it intersects with this line here. So the atheroma volume increases when it's above 80, neutral at 70, and starts to decrease when you start reaching less than 60. And that's very important if you do a serial IVA study, which is actually a surrogate for plaque volume. So you have to have the more intense statin with a greater lipid lowering to impact the atheroma. Now, we've had a lot of recent studies using PCSK9 inhibitors, and I'd like to take this opportunity to describe the Fourier outcome study. In the Fourier outcome study, evolocumab was used on top of a high-intensity statin and enrolled patients with a history of MI, non-hemorrhagic stroke, or symptomatic PAD plus risk factors. In addition, the patient had to be on a statin or ezetimibe. They had a starting LDL of over 70. Most of these patients were male, a little bit older than our patients, 63. CAD, PAD, and stroke. Additional risk factors were there. 70% on high-intensity statin and 30% on moderate-intensity statin and 5% on ezetimibe. The LDL here was knocked down on top of high-intensity statin to a remarkably low average LDL of between 30 and 40 with evolocumab and the statin, as opposed to placebo, which statin only was about 90. There was a 57% average reduction across time and 63% initial reduction. The point is that 47% of the patients received an LDL of less than 25 within the first year, 48 weeks. So very early and very intensive reduction of LDL. Now, they did a post hoc analysis. The majority of the patients who received the PCSK9 inhibitor, 80%, got a greater than 50% reduction of LDL within 4 weeks, and 94% of the patients had a 50% reduction or more by year 1. So this is important. The majority of patients with this add-on therapy on top of statins achieved the greater than 50% reduction required by the guidelines, and also achieved the less than 55 milligrams per deciliter required by the European guideline and certainly the American guidelines. So overall, 99% of patients had a substantial LDL reduction, but the majority reached the 2 targets that the rigorous ESC guidelines recommend. Now, how does this impact outcome? So it's very clear. With the composite of death, MI, stroke, or revascularization, there was a 2% absolute and a 15% relative risk reduction starting at 12 months after enrollment. And the secondary endpoint of CV death, MI, or stroke, which is a more powerful endpoint, again, 20% relative risk reduction starting again at 12 months and extending out to 36 months. Primarily driven by reduction in MI and stroke and myocardial revascularization. So across the board, the primary composite endpoint was significantly lower for the evolocumab, significantly lower for MI, hospitalization, and stroke. It was not significant for cardiovascular death. The number of events was pretty small in both arms. And therefore, overall, if you take the important composite endpoint, it was a positive study. The evolocumab study, they actually looked specifically now at patients who have even higher risk. So patients with a heart attack that was less than 2 years, this is why it's in the guidelines, a recent MI. Those patients, as we said, are the highest risk of having an MI because of the LDL being elevated within the first year. These patients get a 24% relative risk reduction and a 3% absolute over 3 years. More than 2 MIs, so patients with recurrent cardiovascular events in spite of a statin, again, 21% relative risk reduction. Multi-vessel coronary artery disease, look at this one, 3% absolute and 30% relative risk. So when you have a patient with diffuse coronary artery disease, multiple heart attacks, or a recent heart attack in spite of being on a statin, there is a tremendous benefit to more aggressive, more intensive, earlier lipid lowering. Now, the additional analysis of the recent MI patient, less than 12 months, had a greater reduction. In other words, the earlier, the better. And we've actually seen this, less than 12 months here, the risk reduction is 3.7% versus 1% for overall. And in a patient with a composite endpoint, again, less than 12 months, recent event, 3%. So the earlier you impact this, the better. The long-term solution is always to have an early, progressive, aggressive intervention. So one of the other aspects is that when you looked at whether you achieved the ACC-AHA guideline of 70 or the ESC guideline of 55, look at this. In the evolocumab arm, in the highest risk patients with the recent MI, 83% achieved the LDL less than 55, 91% achieved the LDL of less than 50, and 63% achieved the LDL less than 40. So therefore, this actually combination therapy within 4 weeks allows you to achieve in the highest risk patient the most important number, which is 55, 40, and of course to a lesser, in even more complete extent, 70. So no matter what guideline you use, and I think we should use the European guideline because it's more applicable to our high-risk population, we really have to achieve the LDL, and this is an important tool to do so. Now, is there any safety issues with the use of very low LDL? Actually not. The risk of rhabdomyolysis was the same as placebo. The risk of neurocognitive events was the same as placebo. The only thing that was noted was a very slight increase in injection site reaction, no allergies, no new onset of diabetes, and no serious adverse events. The Osler study was another study. This was an open label extension in patients with familial hyperlipidemia. The benefit of this study, it's a long-term study. They go for almost 5 years, and it's probably one of the longest PCSK9 studies to look at the long-term safety and efficacy. So these patients started with a mean LDL of 140. There was about a 50 to 55% reduction of their LDL across the years, year 2, 3, 4, and 5. So it's consistent, and the discontinuation rate for the evolocumab was actually very low, 1% per year. And the important point is that those patients started with very high LDLs, and then they maintained this 60% reduction from baseline for over 5 years. So it's very robust, and the average LDL over 5 years was 1.58, which brings you very close to the European guideline of 1.4 over 5 years. And that's kind of an important point to consider. Glagov was another study. It was a study that looked at intravascular ultrasound. And again, on top of lipid-lowering therapy, they looked at IVUS. And again, that showed the remodeling was significant if the LDL, excuse me, if the LDL was less than 70 and the patients had significant change in atheroma volume. So this is just coming to the most recent study. This is called the EVOPAC study. This was recently published in the American College of Cardiology Journal. And this was a specifically acute ACS patients. So those patients actually received evolocumab in the hospital in addition to high intensity statin, and at the presenting with ACS, and their LDLs had to be greater than 70 if they were on a statin, or greater than 90 on moderate intensity statin, or treatment naive 125. So the LDL wasn't the primary enrollment criteria. It was actually recent ACS. And they added atorvastatin to all groups, and then evolocumab versus placebo. So what was seen was in the patients, there were 37% STEMI, 63% were non-STEMI, and the study enrollment was almost 100% for the STEMI patients within 24 hours, and up to 72 hours for the non-STEMI patients. Okay, most of the patients received PCI, some medical therapy, and a small percentage were CABG. The primary endpoint was reduction of LDL at 4 weeks and then 8 weeks. And while you might think that's a very short study, but it's important. Look what happens here. Within this very rapid evolution, the average LDL dropped from 77 to 31, and from 80 to 31, and maintained that 77% reduction across the board in the 4 to 8 weeks. 78% of the patients did not have a statin at baseline, and they were discharged on a statin. As we said, the majority were non-STEMI, and 84% of the patients had a PCI. So very important that you get this additional 40% lowering to this very powerful LDL target. The 97% of the patients achieved an LDL of less than 70, as opposed to only 30 with high-intensity statin. And 91% of patients achieved an LDL of 55, which is the ESC target, with the combination of evolocumab and statin. Any safety signals? None. Actually, the adverse events resulting in discontinuation were lower in evolocumab, less LFTs, no neurocognitive, very slight local site reaction, almost the same as placebo, and no other physical abnormalities. The EVAC study is a more recent study, is again non-STEMIs with troponin elevation, and they were looking at evolocumab again in the recent post-ACS patient. It's a small study, was just presented at ESC in August. And again, added to statin therapy, very significant reduction of LDL throughout the hospitalization from day 1, 3, 4, and 7, and continuing out to 30 days, with a 60% reduction from baseline, and a 61% from baseline, with a difference to placebo of almost 48%. And the placebo arm, of course, was receiving high-intensity statin. So the majority of patients, again, with early initiation of triple combination, dual combination therapy, majority reaches the LDL target of less than 70, less than 55, and maintains that at the time of discharge, which is the most important vulnerable period. Hospital discharge, 30-day follow-up, and the first year. Again, adverse events were minimal. So what happens when we go to the outpatient setting? So back to our case, right? So this is the 64-year-old female, inferior STEMI with PCI, hyperlipidemia, hypertension, high-intensity statin and ACE prior to discharge, pre-treatment LDL of 100. At the time of discharge, LDL is 90. What is her classification? American guidelines, recent ACS within the past 12 months, right? She just had an ACS. And she also has, by the high risk condition, she's over 65. She has hypertension. She's not diabetic, right? She's also had a recent MI, but it's not the recurrent MI. She doesn't have symptomatic PAD. So it becomes very important when you're assessing the patient is not just to look at their LDL, but also to look at these other factors. So if this patient had a prior MI and this is her second MI on a statin with an LDL of 100, is that sufficient? No, the guideline will tell you that her target is a 50% reduction and to achieve an LDL of less than 40. So this would have to drop to at least 40 to be compliant with the ESC guidelines. If the patient had diabetes, that would increase her risk. If the patient had peripheral artery disease, then her target would be more aggressive. So anyhow, the patient is a very high risk patient, according to both sets of guidelines, and the LDL needs to be intensified very early at the time of discharge with non-statin therapy. So as we said, her risk classification is very high risk ASCVD. She had a high intensity statin at baseline and her LDL was 100 at the time of her infarct on a high intensity statin. So to reach the 50% and less than 40 by ESC guideline, the patient would have to be added an ezetimibe at least, if not a PCSK9 inhibitor. So we decided with PCSK9 inhibitor because we need the 50% reduction. And at the 1 month visit, look at her LDL, 36 milligrams per deciliter, and a greater than 50% reduction. So you went from 100, 50% is 50. You went below 55 to 40 because this is a recent post-ACS very high risk patient and you reached 36. So is this acceptable as your therapeutic target? When do you normally check lipid panel after discharge? And based on this lipid panel, what are you going to do? Do you leave her alone, intensify, or repeat it again in 3 months and make sure that you are still at this very potent target? So these are the different items that we discussed at the beginning. Multiple action points and times that you will be able to look at the LDL, reassess the risk, and reduce the risk of future events. And as we said, this starts in the hospital. LDL, 1 to 3 months. Repeat the lipid panel. Reassess the lipid lowering therapy. Re-emphasize lifestyle lowering and continue cardiac rehab. 6 months, the same journey. LDL, again, LDL is related to recurrent cardiovascular events. Reassess the medication. 12 months, again, confirm compliance and make sure the patient remains in that LDL target, because once you are very high risk, your recurrent cardiovascular event increases fourfold. So in summary, recurrent cardiovascular events is the highest within the first year after an event and persists for very long afterwards. The guideline recommendations for identification and management of very high risk can allow you to reduce the risk of cardiovascular events, and the earlier, more intensive, rapid intensification is very beneficial in the first year. Intensification of lipid lowering, addition of PCSK9 or ezetimibe to high-intensity statin after MI can help majority of patients achieve the LDL target, which I recommended the ESC guideline, of less than 1.4 or 1.0 in patients with recurrent events. Multiple action opportunities exist, and many times we see these patients post-MI, allowing us to do the LDL frequently, repetitively, monitor and educate patients, and therefore maintain the LDL level that lowers their risk of cardiovascular events. And thank you very much for that. So,
excellent, Dr. Hani. This is great. We have I don't know. We got multiple questions in the Q&A panel. So I don't know if you want to take any of them. I mean, I see the first question up there. Is there a harm threshold for reducing LDL by a combination with lipid lowering? And I saw that slide that way you showed the, the low LDL levels. And can you comment on it?
Sure. So this was actually an FDA mandated evaluation to see if there's any harm to very low LDL. As a matter of fact, this was actually shown to be the exact opposite, right? Because we have this intensive reduction of myocardial infarction, stroke, there is no increase in new onset of diabetes. There was a story in the past with very low LDL, does it increase your risk of dementia? As a matter of fact, the FDA mandated a study called the Ebbinghaus study, where about 2,000 patients underwent weekly neurocognitive tests, اختبار ذكاء, every week for the entire duration of the study. And can you believe that the patients who had a very low LDL actually had a better score? In other words, it makes you less likely to have multi-infarct dementia. So there's really no evidence whatsoever that very low LDL, either genetically or pharmacologically, whether it's by PCSK9, ezetimibe, diet, or high-intensity statin, is in any way harmful or not beneficial.
So how would you put this with the, if you look at, say, the Fourier trial, by design, they didn't, if the LDL is lower than, I can't remember the exact figure, but I don't know, 15 or so, those patients were, the dose was changed there. So
yes. So yeah, thank you, Abdul. So in the Odyssey outcome study, that was the
Odyssey, yes.
prevalent. The FDA, because this was the second study and nobody had actually ever seen LDLs in this very low range, they mandated, this is an FDA requirement, not the investigator requirement. They mandated that if the LDL dropped below 15 for 2 readings, that the patient would be removed and enrolled into the placebo arm, right? And
Yeah.
I think that's the problem with that design, is that there was a percentage of patients who reached a very low LDL who were actually removed from the study, but counted against the active treatment arm. And if you remember, those patients with the very low LDL seem to have an increase in their LDL over time because they were no longer receiving the PCSK9 inhibitor. In any case, the FDA did a specific analysis of those very low LDL patients and again found absolutely no signals for harm. So what is recommended in the ACC guideline is that if you have, again, following on this, but it's not truly evidence-based, right? Because those patients did not continue in the study. If you have 2 consecutive readings where the LDL is extremely low, and that's 15, down titrate the dose. So if you're on 150 of alirocumab, go to 75. It's not really easy to do that with the evolocumab because it's every 2 weeks. On the other hand, some other people have done the opposite. They've actually continued the lipid-lowering therapy and maybe removed the ezetimibe, right?
Right.
But I don't honestly know. That's not evidence-based. That was just an FDA-mandated design, and I still think that lower is better. And we're going to see with these newer agents where you can actually achieve LDLs of 10 and 15. There is no harm. There's also some data, by the way, from the genetic patients. So there are some patients who have genetic abnormalities which cause their LDL to be very low. Those are the patients with the PCSK9 loss of function mutation. And those patients live with their entire life with LDLs of 10 and 20, and they have no adverse effects. In fact, in the ARIC study, they had a greater longevity with almost no MIs up to the age of 80.
Dr. Hani, we kept, or our patients keep sending us the WhatsApp messages and some different physicians who who got even websites that talks about the whole conspiracy of lipids and so on. I just want to see, how do you handle it? I know there's, I asked these questions to different colleagues. I just want to see how do you address it?
It's an excellent question, Dr. Abdul, and this is one of the biggest causes of inertia, which we'll discuss in the next talk. So one of the problems is this: there is this conception of cholesterol in the diet and LDL. and they are completely disconnected, right?
Right.
LDL is synthesized in the liver, right? And cells in the brain produce LDL by endogenous biosynthesis. So there's a very nice reference from Professor John Chapman from France, who's one of the world's leading experts in lipids. A baby is born with a complete neurological system with an LDL of 35, 0.75, right? Everything else that accumulates over time is waste, right? Actually, you don't need LDL for production of biohormones because it's endogenous biosynthesis, and you don't need it for nervous function. So this is complete nonsense. It's completely wrong. What comes from the diet is triglycerides, which eventually, because of the connection between VLDL and atherogenic lipoproteins, become stored as LDL. So as you're filling the tank in the liver, you're creating more LDL because of enterohepatic circulation. And there's a very efficient mechanism in most patients to remove this. The problem is there's a lot of familial hyperlipidemia in our region. As you know, we did the study with Dr. Well and our friends in Oman and KSA, where there is 1 in 125 Emiratis have familial hyperlipidemia. So their ability to get rid of the LDL in the liver is impaired even in childhood, right? And I know there's a very famous cardiac surgeon from Saudi Arabia who went on television and said, cholesterol is good and cholesterol medications are bad. This is wrong. This is scientifically not correct. There's no way in the world that this is scientifically correct. So I think the baby analogy is very helpful when we're talking to patients. We also can talk to patients very clearly about the direct relationship, causality between high LDL and mortality, heart attack, and amputation. I think I'm going to show a slide in the Inertia talk about how to address that point with patients.
Okay. How do you see, should we go to the Inertia talk, or should we carry on with this question?
Sure, we can do that and maybe go on to some more questions, if that's okay.
Okay. So another question that I see, estimating lipids, is a fasting sample mandatory, and if so, how long fasting hours are ideal? So how many hours do you ask your patient to fast?
So it's very interesting. It depends on the test you order. So you can order a direct LDL, which we have in Sahan, we have in Cleveland and Imperial. It does not require fasting at all. The particles are not, we're actually counting the number of particles. It has nothing to do with fasting. The impact of food or fasting is actually on triglycerides, okay? So the other test that's available in most other labs is non-HDLC. So almost every lab can give you the non-HDLC because that's a composite of the ApoB atherogenic particles, which is triglycerides and LDL together. It's very accurate. It doesn't need fasting. It can be done right on the spot, and it's not an additional, it's not more expensive. It's part of the normal lipid profile. The lab has to report it. If you have a non-HDLC, remember the non-HDLC target is 30 above your LDL. So if my LDL target is 55, my non-HDLC number is 85. So just think that in your head, just add 30 to the number. So if the lab comes to you and tells you the non-HDLC is 130, then you know that the LDL is 100 and you're at least 60 points above your target.
Okay. What about the point of care?
Well, that's actually fascinating. Point of care testing, Dr. Wael has actually helped us initiate this in our clinic. It's very useful because it takes 6 minutes, okay? And in that, remember, the point of care test does not use direct LDL. It's primarily total cholesterol HDL. So in that one, I use the non-HDLC. It's very well validated. And we found a very close correlation between the non-HDLC and the lab-derived LDL. So in a lipid clinic, a diabetes clinic, an outpatient setting, it's very valuable to teach the patient and do it frequently, right? While the patient is sitting in your clinic, hey, wait a minute, your LDL is not a target. Did you stop taking your statin? Yeah, doctor, I forgot to take it last week. I don't have a muscle pain, all this nonsense. So it's very important to expose non-compliance because non-compliance is one of the major causes of mortality in patients after ACS.
Well, Hani, when it comes to the PCSK, I have experience with it, and I have a good number of patients that have taken it. But when I talk to my colleagues, some of them, they say we don't see high LDLs. Most of our patients are at targets. I don't know if you showed any of the data that talks about how many patients are above targets according to the current guidelines.
Yes. So we had a couple of slides that we showed the DISIS-2 study. So the DISIS-2 study was a registry here in the UAE and many Middle East countries. And in fact, only 40% of patients were actually at the LDL target of 70, right? Mind you, if you looked at the CIFIA study, which used an LDL target of 100, even less were at target. So it's really important to realize that we need to adhere to these targets. Why did these targets come from? The targets come from randomized clinical study and evidence. So the ESC adopted LDL of 55 and the 50% reduction based on Improve It, Fourier, and Odyssey, because all of these studies with add-on therapy, whether it was ezetimibe to high-intensity statin or PCSK9 to high-intensity statin, achieved greater MI reduction when the LDL reached 55. And now that we have medications that can achieve that, it is actually clinically and probably ethically wrong not to try and reach that, because there's a 3% difference in myocardial infarction if the LDL remains above 55 for the first year ACS patient. It's actually related to infarction. So why are we leaving our patients with infarction if we have the resources and the treatment that can do that? It's morally incorrect. And I like to say that we should think like a diabetologist. So remember, our diabetology colleagues are very good about treating to target, treating the A1C to target, treating the LDL to target. So cardiologists need to adopt this, and we don't frequently look at the LDL. That's the problem. You don't relook.
Right. Another question about the lowest acceptable LDL, and I think we talked about that, about the how long would you give PCSK to a patient, and I think I don't know if there's an answer to that for the most of these patients. Once you diagnose them,
that's right.
The high risk, likelihood of them going back to a low risk is
it's impossible.
It's impossible. Someone got an MI or got an established atherosclerosis who's having a above or a high level of LDL. Probably they will need this for their life.
Lifelong, exactly.
Let me know.
Sorry, there's another modifiable risk factor that we don't talk about in these studies, and that is smoking, right? I mean, they've got to stop smoking. But it is far more important to realize that in these studies, there was a large proportion of smokers, and they had benefit. I'm not saying people should continue to smoke, but I think we can reduce. There's two things we can hold in our hands and fix: stop smoking and lower the LDL.
Okay. And we showed that. I mean, we showed in the Hinterheart study, it's, as you have more risk factors, so you need to work on, if you can't work on the weight or on the smoking, you got to work on something that that is achievable for you as or for patient. What do you think about the effect of intermittent fasting combined with statin therapy in controlling LDL?
Okay, I have to admit,
fasting, I don't know. I do water fasting, but
So it's very interesting that we have been religiously we have been fasting for thousands of years, and there's a hadith صوموا تصحوا. So it's fascinating now that there is actually evidence-based medicine that suggests that fasting actually has a significant impact on metabolic syndrome, on diabetes and hyperlipidemia. It's certainly more effective to do intermittent fasting and probably safer than this keto diet. As you know, the keto diet forces your LDL up. It's actually fairly dangerous. We've seen patients on keto diet who are not on a statin where the LDL goes up very high. So I think intermittent fasting makes a lot of sense. I'll have to admit, I'm actually doing it myself. I am a type 2 diabetic with a very strong family history. And it certainly does help. It creates a situation where you don't feel hungry all the time and you're not always looking to eat. And it has made a significant impact, at least to my numbers.
Right. And of course, I mean, when we talk about fasting, and الصيام عندنا, people text it the other way around. In Ramadan, for example, you get the kind of backfires more than getting the benefits of the fasting.
Because we overeat at the end.
Yeah. So in very high LDL and acute Crohn's syndrome patients, can we combine three lipid-lowering statin, ezetimibe, and PCSK9?
Yes.
I can't remember. I had the triple therapy, but I don't know. Maybe in your metabolic clinic or your lipid clinic, Dr. Hani.
So generally because Daman requires you to take ezetimibe. So one of the things that we have to do here that is not specifically in the American guidelines is Daman requires ezetimibe or some trial of ezetimibe as well. So we actually do the following. If I have a very high risk patient whose LDL is double 55, right? So patient's LDL is above 110. I know I need more than a 50% reduction to reach 55. So generally, I will give them the highest intensity statin, which is Atorva 40 or Rasuva 40, plus ezetimibe together. Then I reassess in 4 weeks, okay? If they start with an LDL of above 4.9, which is 200, I know that's not gonna work, right? That's only gonna give you 50%. So I give them 1 month, and then I recheck again. If they're still above 55 and they have not achieved the 50% reduction, then PCSK9 inhibitor is strongly recommended in specifically the post-ACS patient. So generally, our practice has been to be as aggressive as possible. We do allow, of course, for patients that are non-compliant, they don't take this, they don't take that. But part of the emphasis is to do the clinic every month, is to tell them, wait a minute, we can't wait for 3 months. We can't wait for 6 months. We need to fix this right away. So by making this a clinical emphasis, if you tell them to come back in a year, they won't worry about it, right? So I think it's part of a overall medical, psychological, behavioral risk assessment strategy.
But so so you put them on the 3 treatments. So you get someone who's on statin, high dose on ezetimibe, and then they don't get to the target. You come and add a PCSK. What do you drop?
Where?
Or you know, do you drop the ezetimibe, or you keep the triple therapy?
Keep it. Like I said, the only exception if they have these persistent super low LDL. So 15, in other words, you get an LDL 0.3.
So you're guided by, say, LDL of less than 15, which is below what is say reported in the trials. Okay.
Right.
You talked about the insurance, and so there's a question. Any issues with insurance regarding the PCSK?
Plenty of insurance. So I do have some of the answers in the next presentation. I think if the time permits, we can do those. Yeah.
And so what is the cutoff point of low LDL and CKD? You know, 4 or 5. So you know, we talked about the cutoff or the low, you know, or how low should we go, and the safety and non-CKD, CKD. Right. You know, and which one would you use? Which lipid lowering therapy would you prefer for your patients?
Thank you. Excellent question. So I think there's a little bit of confusion about the CKD patient. Now, we have to remember as cardiologists that CKD increases cardiovascular death. Most CKD patients will die before they go to dialysis, right? And end-stage kidney disease patients, 5-fold increase in cardiovascular death, not renal death, right? Because they're on dialysis. They're not going to die of hyperkalemia unless they miss dialysis. So cardiovascular disease is chronic kidney disease and microalbuminuria are extremely powerful markers of cardiovascular death. And we have to pay attention to that. It's not a contraindication to a cath. It's not a statin problem. It's actually death that comes with the CKD. Unfortunately, most of the clinical studies excluded patients with advanced CKD, but we do have studies that included ezetimibe. That was the SHARP study. We also have studies with PCSK9. In fact, there was a specific PCSK9 study with evolocumab that looked at patients with chronic kidney disease, advanced CKD, going down almost to GFR's CKD stages 5. And there was first of all, there was no safety signal, and there was a significant trend to reduction of cardiovascular death with, not cardiovascular death, it was myocardial infarction in the CKD study that was using PCSK9. So I wouldn't limit our patients, but there is data that rosuvastatin, which is primarily excreted by the kidney, is not can increase microalbuminuria, and maybe in a patient with advanced CKD, CKD stages 4 or more, maybe atorvastatin may be more appropriate. But again, the PCSK9 inhibitors have been shown to be safe here because they're not excreted by the kidney and they do not go through that renal elimination mechanism.
So we talked about the subgroup of CKD. What about the elderly? Still, some people are concerned. I think the whole cognitive thing is, is in the mind of people. So
Right.
I got a question here. Patients more than 7 years, should we target a low LDL by PCSK or statins and the side effects?
So it's very interesting because that question was also answered. There's many sub-analyses from the PCSK9 studies. It's fascinating, really. Yeah. The PCSK9 studies have now well over 80,000 patients, so including the Pfizer drug that wasn't approved. And the mean age, as you saw from these studies, was actually 63. And there was a significant component, because remember, these patients were in the US and there's a lot of elderly populations there. So the safety in the older patients was well established. And you know that age over 65 increases your risk of death with myocardial infarction. So the paradox is we have very young patients that have myocardial infarction. They need to be protected early and quickly. But in fact, the older patients also derive benefit because the older you are, the more likely you are to have a fatal cardiovascular event and recurrent MI. And also, these medications have a significant impact on the endpoint of stroke. So LDL lowering was very aggressive in 3 studies. So remember, the Improve It study also had a significant number of patients, about 20-something%, where the LDL achieved was less than 30 with statin and ezetimibe. Okay, that was also analyzed. So it doesn't really matter how you lower the LDL, statin plus ezetimibe, PCSK9 plus all 3, whatever it is, the LDL dropping below 30 has not been shown to increase hemorrhagic stroke, new onset diabetes, does not increase neurocognitive events, does not increase dementia, in fact, reduces the onset of stroke. And really, there's no safety signal to a very low LDL. I think we should really overcome this inertia.
I think that's very important. I think the whole safety of LDL, and I'm sure the whole noise that we hear through all the different reports, either through social media, even it's not just impacting patients, but I think it's even creating a question even among the professionals. But a question here on acute cases, discharging patients. Someone comes with an acute MI, and would you start him on a PCSK in hospital?
Mm-hmm. So this is controversial because it wasn't highlighted in the guidelines, right? So let's be clear, the 3 studies that I showed you, the EVOPAX and the EVAC study, are small, short-range studies, but they enrolled patients who would fall into the very high-risk category, recurrent acute coronary syndrome, on a statin. So say you have a patient. So I saw a patient in the clinic a couple of weeks ago, a young man, about 50 years old, military officer, was on a high-intensity statin, Atorva 80, and had an LDL of 80 about 2 months ago. He was admitted to the military hospital with an acute ST elevation myocardial infarction with an LDL of 80. And mind you, he had a stress test that was negative 2 months earlier. How about that? Okay. So that means that on that statin with the LDL of 80, he was not adequately protected from a plaque rupture event, right? He was rapidly reperfused, didn't have any sequelae, EF was normal, but he also had a lesion in his LAD. So what does that tell me? The guy probably has an aggressive phenotype. We went back, his history, his father had a bypass at the age of 48. We checked his lipoprotein A, it was 310, right? He's not a smoker. So extensive atherosclerosis, a young man on a statin. So that means he has failed statin therapy and an LDL of 80 is not enough for him, right? So he needs to be protected an additional 50% reduction and to be less than 1.0, which is 40, right? So what we do? We put him on a PCSK9 inhibitor, and we brought his LDL down to 0.78, and we brought his lipoprotein A down by about 100 points, and he put him on cardiac rehab and so on. So this is the point. Every patient has their own unique characteristic. It's no longer enough.
And honey, you see, I mean, sometimes I face even a fresh patient, just first time cardiovascular events, first time MI. You run the lipid profile in hospital, and there you can be sure and certain that a high potent statin like Atorva 80 is not going to get him to the target. And you look at their coronary anatomy, and that this patient, he doesn't have maybe a lot of stenotic lesions, but he got a lot of plaque burden, a lot of atherosclerosis that is mild diffuse. So, how would you convince, first thing, how would you treat him? And then, would an insurance cover that? Just going back to insurance.
So I actually have a slide to show this, as a matter of fact, if it's possible. I'll just share my screen. Here it is. So the National Lipid Association, which from the United States, actually talks about the patients who get the greatest benefit of PCSK9 antibody with the current price. In fact, this is the price from last year, and it's also been significantly reduced, right? So the patient that you just described is a patient with extensive ASCVD, extremely high risk, obese, diabetic, hypertensive, lots of uncontrolled risk factors, okay? And the LDL is more than 70, okay? This one, his risk is actually 40% 10-year risk of non-fatal MI, death or stroke in the next 10 years. This patient has the greatest benefit of PCSK9 inhibitor, okay? Now we'll go to the next one, which is a patient on this side. He's very high risk, so a conventional MI patient. So he has maybe single vessel disease, but is diabetic, obese, hyperlipidemic, maybe a smoker. Here, if the LDL is more than 100, then a PCSK9 inhibitor would be useful. If his LDL is 50 or 55, then you're fine with a statin or ezetimibe, right, or both. As you go to a high-risk patient, the LDL has to be greater than 130 for the same risk factors. The exception is this one here. A patient with familial hyperlipidemia, or what we call severe hyperlipidemia, where the starting LDL is 220. This patient, even if they don't have coronary artery disease, even if they're not diabetic, if they have a slightly elevated calcium score, if they have a strong family history, so this needs to be on PCSK9 directly, right? No other testing is needed. But if you're a high-risk patient, LDL 130, LDL 100, LDL 170, and these are on statins in order for this to be cost effective. Now, cost effectiveness isn't the same thing as the guidelines, right? This is one of the points that we have to argue with the insurance companies, because the insurance companies will not talk about cost effectiveness. They're just going to give you an absolute value.
Okay, I think that's great. Now, another point, you talk about the triple therapy. What about, if you are to select a PCSK plus, which one would you go for? Ezetimibe or PCSK with the statin? Or just depends on the scenario? And levels?
So it's a combination of things. I'm going to tell you what's making life very easy is now we have a fixed dose combination that contains a statin and ezetimibe in one pill, right?
Right.
So if we take the ESC approach, we're going to take, first thing, what is the patient's risk? Very high risk patient. We know who these patients are, right? Established ACVD, cardiovascular event, diabetic with risk factors, diabetic with CKD, diabetic with LVH, microalbuminuria, or a high score. Tamam? This patient needs two things: LDL more than 50% reduction and to reach 55 at the same time. The next thing I look at is the starting LDL. If the starting LDL is 200 LDL, there is no way I'm going to get more than 50% with a statin, right? We know that the definition of a high intensity statin is an LDL reduction of 50%, right? So even if I give them 80 milligrams of rosuvastatin, I'm still going to be at an LDL of 100, which is above 55. So I already know that I'm going to have to give them ezetimibe to get a 65% reduction. Remember this, there's some general rules. So high intensity statin is 50%, high intensity plus ezetimibe is 65%, high intensity plus ezetimibe plus PCSK9 is 85%. So I already know that this patient is not going to get to 50 or 60, and I need to get to a 75% or more reduction. That's going to be the triple therapy patient. So it's a prediction in advance. Reality is, I'm going to see the patient on a high intensity statin and ezetimibe combination, see them back in 4 weeks, reassess their LDL, and then add the PCSK9 inhibitor if they haven't achieved the double target. What may make a difference for me is the lipoprotein A, because remember, there is no decrease. Statins increase the lipoprotein A, but if the lipoprotein A is in the triple digits, only PCSK9 inhibitors can lower the lipoprotein A by about 25%. So that might make me more aggressive in the upstream evaluation. So again, it's risk, absolute number, percentage reduction, and how likely I am to reach the target with 2 or more therapies. In fact, combination therapy is now in the guidelines. I mean, I think it's going to be very clear. Why are we not doing this in hypertension? Do we do monotherapy? We don't. We give combination therapy right away. Multiple risk factors, stage 1 hypertension, right? Dual CCB and ACE inhibitor. Why are we not doing it in lipid lowering? It doesn't really make sense. It's only because the data has taken a long time to generate. Improve It was the first study to look at add-on therapy. And then Fourier and Odyssey became the other add-on therapy. And now we have others, by the way. There's bempedoic acid, inclisiran. There's more things that are coming. And it's very clear that monotherapy with statins is not sufficient for the majority of patients.
Question, Dr. Hani. I mean, this is very, uncommon scenario, but question came around it. Mixed familiar hypercholesterolemia.
Yes.
Didn't respond to plasma apheresis. Would it be beneficial to give a PCSK?
That's extremely unusual not to respond to plasmapheresis. So as we know, with severe familial hyperlipidemia, there are 3 approved treatments. Number 1 actually is plasmapheresis and lumitapide. So lumitapide is not a statin at all. It's an MTP inhibitor that actually blocks the entire process of enterohepatic circulation and LDL. So in patients who have been on plasmapheresis, sometimes we can get them off plasmapheresis with lumitapide. Now, there are certain types of familial hyperlipidemia that will respond to PCSK9 inhibitor. And you're going to ask me, how's that possible? If you have homozygous FH, you shouldn't have any activity of the LDL receptor. But remember, you get 2 copies of your LDL, one from your mother and one from your father. So sometimes there is a genotype called defective, in other words, 50% activity from the mother, and negative, 0% activity from the father. So there's a still 25% LDL receptor activity. And if you give these patients PCSK9 inhibitor, they can sometimes lower their LDL by about 20% or 30%. But I have never seen a patient who doesn't respond to plasmapheresis. This is very strange. I mean, plasmapheresis mechanically dialyzes the LDL using special columns. Now, maybe not using the correct columns. So there are something called DALI apheresis, which is a specific apheresis to remove ApoB, not general plasmapheresis. Because remember, we're not removing plasma proteins.
Hani, I remember you had patient or patients at SKMC. Yes. I would ask you, how many patients do you have who went on plasmapheresis? So through your practice, here, at least here in Abu Dhabi.
So actually, this is the grand total of these patients is actually 2. The one that you remember, of course, unfortunately, it's a very sad story. She's a very young woman who had a aortic valve replacement at a young age, peripheral artery disease, and we were able to help her through the activity-based mandate at SKMC for a couple of years. Unfortunately, she recently passed away at the age of 39. Wow. So these are the total number of
very
patients.
Aggressive disease.
Very aggressive disease. Unfortunately, because of the activity, she lives in Dubai and we were no longer able to treat her. So she was without plasmapheresis for the last 2 years. And I think this is the problem. And her daughter, we were trying to get her under the pediatric cardiology ABM, also has FH with an LDL of 490. There's two patients that we actually treated. When we had these patients on LDL apheresis, the LDL would drop from 13 to 3. So it's a very powerful tool, but you have to do it every 10 days for effective removal of LDL. Our friend Dr. Khalid Rasadi has a very large group of patients. I think they have about 17 patients.
And those patients are on PCSK plus, or they just go on plasma apheresis, and that's it.
Yes. So you always would like at least to try, they have to be on a statin, believe it or not, because even in FH, the statin pleiotropic effects seem to have some impact on the cardiovascular inflammation. So even if they're not lowering their LDL. So we have a couple of severe FH patients who may be a compound heterozygous who are not on plasmapheresis, who have had a very good response. One of them actually had an AVR and CABG and a PCI at Mediclinic. You might know the patient. Who started with an LDL of 10 and now has an LDL of 2.6 on very high dose PCSK9, 420 milligrams of evolocumab every 2 weeks, which is the FH dose, plus statin, plus ezetimibe.
Okay, great. I think we're coming to the end of the questions, and we may need to move your talk. Last one was the dose of ezetimibe more than 10 milligrams.
No data.
No
data. So basically, it works at the intestinal brush border and inhibits the Niemann-Pick-like protein. So having more or less doesn't help. It's a total inhibition or not.
Great. Okay, I think we're done with all the questions. I mean, this is the first time I was able to satisfy all the attendees and answering all the questions. But very good questions. I like it. It's and definitely, Dr. Hani, very thorough.
No problem. So we can go to the second portion of the talk. I'll try to make it, because we've covered some of them. I'll try to show some of the slides to help. So I call this pitfalls and barriers in cardiovascular prevention, how to overcome inertia focused on lipids, okay? So one of the things is this is very clear. Diabetes is very common in the UAE. And coronary artery disease is the main cause of mortality in diabetic patients. There's a twofold risk in diabetes of coronary death, MI, and stroke, independent of the other risk factors. So please bear that in mind. And not only do diabetic patients have earlier CVD, so at an earlier age, but also in spite of their age being 14 years younger, they also have more events, more first MI, more unstable angina, more non-fatal MI, almost double for the same age group. See, this is the same age of patients without diabetes. And 51% of diabetic patients will have a recurrent cardiovascular event within 2 years after your first event. So remember the patient with the first myocardial infarction within 12 months, which we said, your diabetic patient with a myocardial infarction has double that risk, even more. So please bear in mind that your diabetic patient with MI is an incredibly high risk of having another heart attack. And we really need to look at these patients not in a benign way at all. Now, I think we referred to this, but I wanted to show you this important slide. This is a meta-analysis of all of the studies that lowered cholesterol. So this is a causal relationship. This is not an association, because whether you lowered the LDL with statins, whether you lowered them with mixed therapies, whether you lowered them with statin, ezetimibe, or PCSK9, it's a linear relationship. Every 1 millimole, 39 milligrams of LDL lowers the CV events by 20%. So on the statin therapy, this is the CTTC meta-analysis, 22% reduction of major cardiovascular events, 20% reduction of cardiovascular mortality, 10% all-cause mortality, every 1 millimole. If you took 300,000 patients with all the therapies pulled together, 23% reduction of major cardiovascular events. This is a 52-study meta-analysis, 320,000 patients with all classes. Statin, ezetimibe, PCSK9, 19% relative risk reduction. It's essentially identical, 20%, 20%, 20%, okay? Every millimole per deciliter. So the opposite is also true. Failure to achieve this reduction in LDL will increase your patient's risk by 20%. What are we waiting for? We have no reason to wait. Now, diabetes and CAD makes it worse. We said this. Worse outcomes for diabetic patients, Diabetes complicates the management because of renal failure. More aggressive multiple risk factor modification is needed. Now look at this, is very important. This is actually from the CARD study. This is the cardiovascular risk in diabetes. And they looked at these diabetic patients. Again, 23% reduction of major cardiovascular events in diabetics with every 39 milligrams per deciliter or 1 millimole. But that leaves you with 77% risk in the diabetic patient. Why is that? Because they still have diabetes, right? Because they have metabolic syndrome, because they're still hypertensive, they smoke, and they have atherogenic dyslipidemia. So I've heard a lot of talks, and I've given talks myself about residual risk. But what is residual risk? What is residual risk? How to influence residual risk in metabolic syndrome and CAD? What's the priority? It is still, first and foremost, very aggressive LDL lowering. And once you have achieved the LDL lowering required by the guidelines, 55 milligrams per deciliter, 1.4, and a 50% reduction, then you look at aggressive blood pressure lowering, and then triglycerides, and then CRP, and then adding antithrombotic therapy, and then looking at the SGLT2 and the GLP-1, and then weight, obesity, and circumference. All of these are very important, don't get me wrong, but you have to fix the LDL first, because in all of these other additional add-on therapy trials, every patient was on a high-intensity statin, and almost all of them had an LDL of less than 70. To impact additional risk, you have to impact the primary risk of LDL. Now, very important to look at in the PCSK9 studies, and this is really, really important. Look at this key issue. And this is the alirocumab study. It's exactly the same thing. Whether the patients were diabetic or non-diabetic, if they had normal glycemia or not, there's a significant reduction of major cardiovascular events. And it didn't really matter what your background was. You must lower the LDL in order to achieve the effect. So to summarize again, LDL and cardiovascular disease are causal, and it is the most readily modifiable risk factor. Long-term elevation of LDL increases the risk, including MI. Consistent long-term LDL lowering is essential in all ASCVD patients to reduce the risk of cardiovascular events. And long-term studies, which we've seen now, the Osler long-term study, and we have something also called Orion, are ongoing to show the efficacy of long-term LDL lowering in ASCVD events and MI. So these are the clinical pitfalls. Physician, this is our responsibility. Patient, up here, patients have struggles with statins and other therapies, and insurance. So I'm gonna go through them and go through these in some more detail. This is the problem here. The guidelines have become more rigorous and more aggressive. Why? Because we can and have tools now to save more lives. So we have to adhere to the guidelines. However, there's a lot of physician inertia in attaining the guidelines because they're more aggressive, they're more difficult. First of all, we incorrectly assess risk frequently. Second, we do not remeasure the LDL, and the guidelines are very clear. Measure every 1 to 3 months until you reach the target. Third, failure to titrate lipid-lowering therapy due to theoretical concerns about symptoms, age, whatever it is. It's not real. Next is the patient. The patient often has poor compliance and adherence. Reality is statin intolerance, true, absolute intolerance. I cannot take any statin is not common. It's quite rare. Statin non-response is a biological effect. So if you give a patient a high-intensity statin, they don't respond. Think of familial hyperlipidemia, add the additional therapies. Thirdly, abnormal LFTs are usually transient. They're usually due to non-alcoholic fatty liver disease or something else like an antibiotic or non-steroidals or alcohol or something that the patient's not telling you. So really, compliance and adherence can be well managed if the patient is well informed and the physician is guiding them properly. And finally, we have this huge problem of challenge due to insurance denials, which is unethical and inappropriate. And I want you to see this is the call to action paper that was published in Circulation. These are the opportunities that we miss in cardiology in prevention and treatment. Failure to make risk factor modifications can reduce the odds of cardiovascular disease by 80%, as we have seen. Failure to give the patient more education in order to them to be more compliant. Failure to diagnose. Remember, 40% of heart attacks occur in patients with undiagnosed cardiovascular disease. 30% in undiagnosed hypertension, and 30% in undiagnosed hyperlipidemia, because we don't look frequently enough. Failure to use first-line treatments, 67% of non-adherent patients on statins in 1 year. Failure to use advanced therapies in appropriate patients. 1/3 of the patients on PCSK9 actually get approved. The majority have denials. And also supportive care, especially in statin patients, we don't tell them about the side effects enough. Now, the guidelines have become more difficult. I will acknowledge that freely and strongly. The guidelines have told us in the high-risk patient, very high-risk patient, and second event within 2 years, it has gone from a or to an and. 50% reduction and less than 1.5, 1.8, which is 70, 1.4, which is 55, and 1.0, which is 40. We need to achieve this because this saves lives. The guidelines didn't put that for fun. So for us, what we have to do and recognize our really our failures, titration and intensity, advanced therapies, and rechecking of LDL. Now, the guidelines are very clear. Very high-risk patients are potential candidates for maximum statin plus 2 non-statins, ezetimibe and PCSK9 inhibitor. And we've seen the patients that are recent acute MI, recent cardiovascular events, familial hyperlipidemia, established ASCVD, diabetes, and multiple risk factors. And this is the ACE guideline. So there are 2 guidelines here. What is the problem? I think one of the inertias is lack of adoption, or even, I'm sorry to say this, lack of knowledge of where the risk and the level of LDL is. And this is important because the guidelines have changed 3 times in the last 2 years. This is the AHA 2018, EAS and ESC 2019, ACE guidelines 2017, 18, and 20. Second inertia, incorrect classification of risk in high-risk patients. So our friends in SKMC, Dr. Wael and Dr. Sharif Bakir and the team at Al Ain University actually took all of these scoring systems, Framingham, ACC pooled risk equation, NCETP, and Euroscore, and they correlated them to a large Abu Dhabi cohort of patients with known coronary artery disease. Guess what? 55% concordance. It's like guessing, tossing a coin. So the score system was poorly validated between these European American risk assessment and actual risk in the UAE. And this is a challenge in any patient seeing these, any doctor seeing these patients. And this really confuses the doctor. When you see a number that tells you the patient's low risk, you're not likely to react to that number. And that's a very dangerous thing. I think as a society, Emirates Cardiac Society, we have to get into the Waqaya database and try to get this information. And some data we can get from ICLDC. Remember, ICLDC has been available. They have data for the last 11 years. They treat about 100,000 patients. They have some very good news here. 93% of the patients are on lipid-lowering therapy. Remember, these are high-risk patients with diabetes. Their calculation is that about 30% of patients have high cardiovascular risk, okay? Moderate risk here and high risk there. And only 9% of the patients were identified to have heart disease. What does this really mean? It means that the calculator is not properly identifying the cardiovascular risk in patients who are not symptomatic, and therefore they're not being intensified appropriately. And Dr. Abdul Majid showed this, the inertia in the Cepheus Gulf study and the DICES Middle East study. Only 1/3 of patients of very high risk post-MI patients were receiving high-intensity statin, which is completely wrong. A patient with a post-MI situation or high risk has to be on a high-intensity statin at least. And look at this, 77% of patients in the Cepheus Gulf study remained on the same dose of study since the first day it was prescribed. So we are, as physicians, we are not up-titrating, we are not reaching goals, and we are not modifying therapy in the outpatient setting. Now, we had many questions about the safety of very low LDL. So this is the Odyssey outcome study, and look at this. Neurological events were actually less in patients who had an LDL less than 25. Look at this, right? Neurocognitive events were less, musculoskeletal events were the same, diabetes was the same. So there was no increase in risk in neurocognitive, ophthalmological, and musculoskeletal events in patients with LDL less than 25. The only thing was a slight change in cataracts, but overall, this was no different than the placebo arm. Because remember, this table is looking at less than 25 and more than 25. But compared to placebo arm, there was no difference in cataracts with a very low LDL. In the Fourier study, which was a slightly larger study, again, they looked at patients with LDLs all the way down to less than 20 and less than 50. Look at this. Again, no difference in adverse events. Serious adverse events, cancer, intracranial bleeding, cognitive impairment across the 5 different groups with very low LDL or LDLs in the more conventional range. There's no safety reason and no reason not to get a very low LDL. About the patient now. The patient is the most important partner, of course, in these discussions. These patients struggle with hyperlipidemia. Poor adherence and compliance is a basic problem, but we can do something about it, okay? So non-adherence is very common. This is an American study where 14,000 patients with post-MI and ASCVD, there were 66% of patients who were not fully compliant. Some of them were non-adherent at all, and some were partially adherent. Only a third of post-MI patients were totally adherent. Why do we care about this? Look at this. The partially adherent patients, which was 57%, actually had a doubling of their MACE events. So whether it was partially adherent between 40 and 79% of the time, or non-adherent at all, their MACE events increased from 20% in the totally adherent patients to 45% whether they were partially or totally adherent. So if you don't take the statin every single day, your risk of a heart attack is gonna go up to 45% in 42 months, which is basically double that if you stay on the statin. And we can do better also with the statin as well. Why is this a problem? Because statins have to be taken every day, as with ezetimibe. So on average from this insurance study, only out of 365 days, 184 days were taking the oral therapy. The PCSK9 inhibitors were a little better because you take them every 14 days. So that's, or monthly if you use the higher dose. So the average days of therapy was a lot better, 246, so 100 more days with PCSK9 inhibitors. So patients have barriers. They forget, they don't want to take pills. When they take statins every day, it reminds them that they're ill. They are also distressed about being dependent. One of them, they will tell you, when can I stop my Plavix? When can I stop my statin? And the problem is that non-adherence to statins is associated with a 60% increase of CV death and about 125,000 preventable deaths in the US per year. And therefore, that's where injectable therapies make a lot of sense. Inertia number 4, not repeating the LDL. This is a direct cut from the guidelines. Assess adherence and percentage response to LDL plus lifestyle with repeat lipid lowering from 4 to 12 weeks after statin initiation, or dose adjustment, repeat every 3 to 12 months until you reach the LDL target. We looked at a survey in multiple large centers in cardiology clinics. Unlike diabetes clinics, most patients only get an LDL once a year. This is not a good practice at all. And again, from the United States, 1/3 of the patients with ASCVD were treated by their doctors without knowing their LDL level in the previous 2 years. Can you imagine that? Endocrinologists, on the other hand, are more likely to do frequent lipid testing, followed by cardiologists and GPs. So we really need to change this. This is not clinically meaningful or right. And if you look at this, is actually a very large registry of patients with ASCVD, 2 million patients, okay? Those patients, 31% achieving only an LDL of less than 70 were only receiving a statin. And in fact, it was younger people, African Americans and females were less likely to achieve LDL less than 70 on statin monotherapy alone. So this is very important. And to achieve an LDL of less than 70 is no longer enough. And therefore statin monotherapy or low dose statin therapy is no longer sufficient to protect our patients. And in fact, the physicians were more likely to stick to the guidelines if the patient had an MI. Stable coronary artery disease didn't excite a lot of people. And again, less than 50% of those 2 million patients were treated according to the old guidelines. And it actually gets worse if you have diabetic patients because they need to be on a higher statin dose and they need to have more prevention. And in fact, the minority in primary prevention are getting the correct treatment and reaching the goals. Insurance, last point, big inertia now. In spite of the need for novel advanced therapies such as PCSK9 inhibitors, insurance is a big barrier. Insurance companies care about the short-term plan and cost, not prevention. PCSK9 inhibitors were initially more expensive. They were actually $14,000 at the time of enrollment. And now they've actually come down to less than $4,000 a year. However, still with the lower cost, again, very high risk patients, familial hyperlipidemia patients on maximum intensity statin are also at risk and need to be on these treatments. The insurance companies have made it difficult for you and me by making long, tedious approval processes for PCSK9, but it is worth it because we're going to save the patient mortality. And if the insurance companies were smart, they'd realize that the cost of medication per year is 1/10 of the cost of a bypass or a CCU admission or a myocardial infarction. So again, I've shown you this slide in a different way. The highest risk patient, multiple risk factors, multiple areas of coronary artery disease, peripheral artery disease, and so on, and on a statin with an LDL of over 70 clearly benefit from a PCSK9 inhibitor in terms of cost. And I wish the insurance companies would understand this fact and not keep fighting us on it. Unfortunately, the insurance denies 57%, and this is in the United States, of patients who are highly indicated. So patients with ASCVD, familial hyperlipidemia, unable to get 3 out of 4 prescriptions without a direct appeal. So that's really a miserable thing of the insurance companies. I think as a medical society, Abdul Majid being the president, I think we have to address this with Daman. And this is the last thing I'm going to show you. This is the Da Vinci study. It was just published in AHA, and this is an article from Atherosclerosis, looking at cholesterol management in general and how we need to reduce the implementation gap. So this study looked at a huge number of patients from the Europe who were on lipid-lowering therapy. Now, since the guidelines have become more aggressive, 2019, the targets is 55. Even less patients have achieved the target on statin. So only 22% of patients on statin are achieving LDL of 55. 21% with ezetimibe less than 55. 58% on PCSK9 less than 55. So that means that monotherapy with statins is preventing us from reaching the new guideline recommended goal. And the recommendation was in Europe, where there's 22 million patients with ASCVD, the data suggests that 18 million patients will not reach the LDL goals unless we take steps to systematically consider combination therapy for those at higher risk in whom the lowest LDL goals are recommended. And we need, as cardiologists and people practicing in lipids, to recognize the lessons of hypertension, where combination therapy has become the norm. And this is also an extrapolation of this study. If you take these patients from 18 countries, there's almost 3,000 patients in this study, and you take all of the patients who started with an LDL of 1.8, and you shift them to an LDL of 1.4, and these are patients with high cardiovascular risk. What happens to their 10-year risk? It goes from 35 to 30. So that's significant, but we should be trying to go even lower, right? So shifting the population risk from 35 to 30, from 1.8 LDL 70 to 55, is this enough? But do you even think you can achieve that in large populations with all the inertias we mentioned, with statins being low dose, not being titrated, and even statin monotherapy? There's an urgent need now for a paradigm shift in lipid risk management. Theoretically speaking, if you put patients on statins, ezetimibe, and PCSK9, 99% of our ASCVD patients should reach an LDL of less than 70. In real world practice, only 25% reach that. And that means these 70% of patients are at risk for myocardial infarction, stroke, and heart attack that we can and will prevent if we are more aggressive in the treatment. So in conclusion, many patients with ASCVD in the United States and worldwide are not achieving their LDL on statin alone. Poor adherence, lack of persistence is common, associated with increased CVD mortality. Prescribing of lipid lowering is suboptimal and not consistent with the guidelines. An addition of non-statins to high-intensity statins improves CV outcome in patients with ASCVD, including ezetimibe and PCSK9 inhibitors. And thank you very much again for your time.
Great. Thank you so much, Dr. Hani. This is, you know, it's very interesting when we see, you know, all these opportunities and all the challenges to get the patient, you know, treated
Oh,
to targets. It's you know, there's a lot of barriers, and a good part of it falls on us as a, you know, as a healthcare community and as an individual physicians to, you know, to identify the risk and then fighting, you know, to get the patient towards that target. I know the insurance issue is a challenge, and I know it's not, you know, the payers sometimes can be multiple payers, and every payer got a different rules. Of course, in UAE, Oman is the largest payer, but I understand how much challenging it can be, and some of the physicians' inertia or you know, you know, yeah, not addressing it is just because they know they don't want to take that route because they know it's a very difficult route to get the approvals. So they would you know, they would take the route of the easy route, which is you know, which is statins and treatment. I don't have any much of a questions. I don't know if you you know, if you have anything to add, Doctor, before we close. I know we're close.
if there's time, there's a couple of very quick cases we can, if there's an
Oh,
opportunity, or
sure. Why don't we show that?
sure.
Someone commented on familiar hyperlipidemia, and he says it's very aggressive disease. I came through a patient not responded even to plasmapheresis and passed away very young, and not only him, but his younger brother as well. So I don't know. Do you have a يعني someone in UAE who takes care of these patients? So just to educate our attendees to, you know, to send this patient to. يعني do
So
we have someone? يعني I know you are interested in these patients, and I don't know if you still taking them. And
so thank you. This is a very important question. So I think we lack the definition of what's called a proper lipid clinic, but we have a sort of established one at Cleveland and one at Imperial College Diabetes Center. And it comes essentially by referral. So the first thing is recognition of FH. Now remember, FH is not actually a lipid disorder. It's a cardiovascular disease with the LDL as a biomarker. So the trick is, if you have patients with family history and high LDL, make them screen their children. Tell them to check their children. This is how we do it, right? This is the important thing. Genetic testing is not universally available. You don't need it. If the LDL is higher than expected, if they actually have an LDL of more than 4.9, if it's 190 or above, it's FH until proven otherwise. That's number one. Ask the family history. Many patients don't understand the link between family history and premature cardiovascular disease. Premature CVD is earlier myocardial infarction or stroke, less than 55 in a male or 65 in a female. A simple question, right? Number three, you put them on a statin and they don't respond within a month. You put them on a high intensity statin. Statin non-responder equals no receptor in the liver. This is a rule, and they are probably FH. Now, apart from the lipids, FH patients, according to we've written some consensus guidelines actually with the group in Oman and KSA. These patients need special cardiovascular testing. So not only should you do an ECG, you need to do an ankle brachial index, carotid Doppler. You have to do a coronary calcium score. And in fact, if it's familial hyperlipidemia, in young patients, coronary CT angiogram, not a coronary calcium score. A stress test is useless. Stress test is only going to show you obstructive CAD. Oftentimes, patients have early plaque. So we have actually looked at these patients, and we've seen that sometimes the calcium score is 0, but they have extensive soft plaque. So it's a cardiovascular disease, should be managed really with a cardiologist directly, or with the assistance of a cardiologist with this interest. And I think Dr. Wael has established a similar clinic in Cleveland Clinic. I have the same one in Imperial and in Abu Dhabi, and one of our colleagues, Dr. Sarah Qureshi, has a lipid clinic in Al Ain ICLDC. But remember, the serious problem is not doing the correct cardiovascular testing. And it might be difficult to convince the insurance company, but you have to do it. This is a FH guideline. They are different. Why? Because they have high cholesterol since birth. They are not waiting until 30 years to have LDL. These are kids who have an LDL of 6 and 7. And the second thing is to encourage family screening. And you know the guidelines for FH in children, treat with a statin at the age of 5 years old, 5. So really it's an end-to-end issue, and it's very common in the UAE among the UAE national population.
I totally understand it, and I think you're totally right. I mean, we see those young patients, you know, the 30s that had a stress test, and they come and then they present sometime later, you know, with either a massive infarction or a sudden cardiac death, and those are kind of missed patients, you know. So they, you know, the usual pathway of investigating this patient should be, you know, more aggressively.
The other thing is there should be routine use of lipoprotein A. So lipoprotein A is genetically predetermined. 75% of the population doesn't have it, and 25% have it since birth. So a lipoprotein A above 75 confers a lifetime risk of 4 times higher myocardial infarction. Some of the patients we see have a lipoprotein A of over 300. And the reason that you need to do that is to early intensify statin therapy and then add PCSK9 inhibitor fairly quickly.
Great. Okay, let's go quick over the case in 3 minutes.
Yes.
So
this comes to the familial hyperlipidemia. So this is a 42-year-old woman recently diagnosed with heterozygous FH for follow-up. She's hypertensive and elevated lipoprotein A. I think sort of pointed out. Family history. Multi-vessel CABG in her father, age of 53, also had severe hyperlipidemia. Brother, severe hyperlipidemia, PCA after angina at 47 years. Mother, breast cancer. Physical exam, normal. So this is really a clue. Even if you didn't know that she has FH, this is FH. It's talking to you right now. Why would a 42-year-old woman have a very high LDL? Now look at this. She's on atorvastatin 80, ezetimibe 10, total cholesterol 195, LDL 125, in spite of this massive dose of atorvastatin and ezetimibe in a premenopausal female. And remember, the lipoprotein A is high. So in spite of a 62% reduction of her starting LDL, it was actually over 250, is she at target? No, she's not, right? Is she protected? So what am I going to do? I've given her the maximum dose of statin. It's pretty clear. So we don't have time to go through discussion. Would you add fenofibrate? Would you add a bile acid resin, bempedoic acid, or PCSK9 inhibitor? It's very clear. This patient is FH, terrible family history, high lipoprotein A. This is the guideline. You don't do any risk stratification in this patient. This is directly here. LDL starting more than 190, 4.8, high intensity statin, go to PCSK9 inhibitor. Severe primary hypercholesterolemia, PCSK9 inhibitor. If the baseline LDL is over 220, on treatment LDL more than 130, right? And if you have documented FH, so the difference between line 1 and line 2, family history. This patient has a terrible family history. So at this point, even if it's over 100, you have to give them a PCSK9 inhibitor. If they only have severe primary hyperlipidemia, you could wait until the LDL responds to a statin. But then she has both, okay? Do we have time, or should we wrap it up at this point?
I don't know if you want to go another case, if it's quick.
It's fairly quick. 73-year-old woman. This is actually from the United States with ASCVD. So she's menopause at the age of 52, gestational diabetes, hypertensive, impaired fasting glucose, metabolic syndrome. So the risk now is being driven by the metabolic syndrome. Her mother had diabetes and a family history of angina and abnormal nuclear stress test. So remember, this is a 73-year-old. So pravastatin 10 milligrams, she had leg cramps, 10 milligrams of atorvastatin and rosuvastatin leg cramps as well, ezetimibe 10, hypertension and diabetes, normotensive. What's the problem here? She has an LDL of 155. Her 10-year risk is 17.1. What am I going to do? She's now had statin intolerance and is only on a tiny dose of pravastatin and ezetimibe, right? So what's the next step? Is her LDL a target? No, it's not. So again, this is a good candidate for PCSK9, but why? Because she's a high cardiovascular risk patient, cannot tolerate statins after an actual trial of 3 different statins. And that's the trick with statin intolerance and ezetimibe, not at target, high 10-year risk. Okay, so the trick in this case is that you have to try 3 different statins at very low doses, plus ezetimibe. If they don't meet target, and they will not likely do though, then a PCSK9 is recommended because she's diabetic and has a high 10-year risk. All right.
Great. I think you know we got a couple of questions. I don't know if we should you know, try to respect the time of our audience and our attendees, but maybe in a minute, so we don't you know, we don't let someone down. Yani. What about triglyceride as risk factor for atherosclerotic disease? Yani, if we can
Absolutely.
get it in one line.
Residual risk after the LDL is controlled. If your non-HDLC is above target or your triglycerides above 150, then addition of a omega-3 or fibrate, and specifically omega-3 is mentioned in the guidelines, but after you fix your LDL first LDL. Okay.
So LDL is first. End-stage kidney disease patient on maintenance hemodialysis suddenly suffers an MI. Do we need to give them a high-intensity statin plus minus ezetimibe? If yes, what is the target LDL? This is a very high risk. End-stage kidney disease, established atherosclerosis and cardiovascular event.
So empirically, this is the point. Again, I can tell you that these patients were not enrolled in the clinical study. There is some controversy in the guidelines, but in this patient who had a myocardial infarction, this is not a primary prevention. This is a patient who needs to have maximum intensification, and probably you will benefit from the use of PCSK9 inhibitors in these patients because they may have some muscular side effects from statins, especially on dialysis.
Highest of the highest risk.
Absolutely.
Thank you, Dr. Han. Jazakallah khair. I mean, this is a very interesting, you know, session. I really enjoyed, you know, the 2 hours, and we'll see you, inshallah, in another events. I'd like to thank our attendees for their, you know, participation and for the questions. Very rich group because they kept us very interactive. I'd like to thank them. The event is an accredited event, and they should follow up with the, you know, with if there's any issues with our event organizer. But definitely, the event organizer is going to share with them their CME hours or certificates.